Hello and a warm welcome. I am very pleased to welcome you to our annual coverage of the European Hematology Congress, which this year took place from June 11th to 14th in Stockholm. Together with Professor Scheid from the University Hospital of Cologne, we have put together a few highlights from study results in various fields. I am a patient myself. My name is Klaus Eisenbeisz, and I am a patient with myeloma, and at the same time, the founder and chairman of Myelom.Online, a nationwide patient and self-help organization for people affected by and living with multiple myeloma. Professor Scheid, you have quite a bit to report to us from the EHA, including some very interesting studies that are somewhat forward-looking, and I am looking forward to you presenting them to us accordingly.
Dear Mr. Eisenbeisz, thank you very much for the invitation and the opportunity to report on some highlights from the last EHA here. Speaking of forward-looking topics, smoldering myeloma has been receiving increasing attention recently. With daratumumab, we have the first approved therapy, but of course we are always discussing a great deal of information about which patients should be treated and whether the currently available therapy is already the end of the line. And I have brought two studies from the EHA to discuss here. First, a study on elranatamab, a bispecific antibody, which we know from relapse therapy, and which was used here as part of the EMN34 study. So the idea was to treat patients with high-risk smoldering myeloma, that is already an advanced smoldering myeloma, right at the threshold to symptomatic myeloma, by means of an early intervention, with ultimately a single agent, namely this antibody, and then to see whether this could prevent progression to symptomatic, can halt the progression to myeloma. The drug was administered subcutaneously according to the known dose escalation scheme, and the entire treatment was planned for 2 years, so a fixed treatment duration. And of course, the focus was on efficacy, but above all, also on the safety of this therapy, because these are patients who generally feel healthy, who usually have no symptoms of disease, and who might only become symptomatic as a result of the therapy itself, if they experience side effects, when they feel side effects. The main question was the efficacy in terms of achieving a complete remission. And then the question was, what about the overall response rate and also the duration of the response, but above all, the safety and tolerability? Not surprisingly, with such an early therapeutic intervention, I have a high response rate. After 6 cycles, the complete remission rate was measured at 30%. Very good remission, partial remission in 74% of cases. The efficacy is, as expected, very high. Also here, referring to 9 months, the progression-free survival rate is 95%, which is also very high. Of course, these are very short observation periods. What is much more important here is to look at the course over years to see how the overall progression is for the patients. But it should already be pointed out here, 4 out of 50 patients discontinued the therapy due to side effects. This is a therapy that is not entirely without risks and is obviously not so easy to administer. Here it is shown again graphically, the response rate on the left after 6 cycles, which was the primary endpoint. So a short-term endpoint after only half a year of therapy. For a therapy that runs for 2 years, I can expect that the depth of remission will improve over time. The CR rate rises to 72% at a median follow-up of 40 months. And there could certainly be even more deep remissions with longer follow-up. Of course, it is important. When minimal residual disease was measured in the bone marrow, this was available for 29 patients here. Then 90% of the patients here were MRD negative. So we see that this deep response is much better measurable in the bone marrow using genetic methods than in the classical assessment of paraprotein in the serum, which we look at for complete remission. But, and this is the big but here, if I treat patients without symptoms with an effective therapy, then they develop symptoms. Most of the time we see mild symptoms in the end. Skin rash, elevated liver values, diarrhea, fatigue. All probably tolerable side effects if the treatment goal seems relevant enough. We see that cytokine release syndrome is relevant during the dose escalation phase, but only grade 1 to 2. However, 2 cases of grade 3 CRS did occur. That too is something you don't want to have. And what I find particularly significant, 14% severe infections. That's definitely an issue that needs to be looked at more closely, because that's something that does call the use of such a therapy somewhat into question. Here, taking a closer look again, on the right, you can see the infections depicted. Most of the infections occurred in the ENT area and the respiratory tract, and there were also some cases of COVID among them. So we see there is a clear signal here that this very effective therapy does indeed lead to significant infections. Half of the patients experienced infections. As mentioned, 14% had severe infections. So in my opinion, there is still a lot of room for improvement here to turn a very effective therapy into a more tolerable one. And of course, we need long-term data to see over a long period of time whether the course of the disease in myeloma, from smoldering myeloma to active myeloma, is truly influenced in a lasting way. To summarize, we can say that we have a clearly high efficacy in the early treatment of this high-risk smoldering myeloma. We have very deep remissions, which we already know from these antibodies. We have a well-known safety profile, which may seem more acceptable in a relapse situation than in this very early form of treatment. And of course, the authors here concluded that it is a potential option for early treatment of high-risk smoldering myeloma. However, if I might elaborate on my comments here on the right side once again, I also think the data are interesting. It is definitely very exciting to think in this direction. The major problem is the infections. I believe that the use of the antibody needs to be adapted to this early form of application. And of course, I see for such a therapy situation quite a long road to approval and also to reimbursement for such therapies. Another study that looked at the same patient cohort, namely, once again, high-risk smoldering myeloma. So patients with significant paraprotein presenting with significant bone marrow infiltration, but who do not yet meet the clinical diagnostic criteria of active myeloma. Here, a more classic approach was chosen with a quadruple combination. We know something similar from first-line therapy with a CD38 antibody, a proteasome inhibitor, an IMID, and dexamethasone. However, it must be said that here the proteasome inhibitor carfilzomib is used, which so far has not been approved for first-line therapy. Very effective and well tolerated, no question. But here a combination was chosen that in this form is also not approved for the treatment of active myeloma. Nevertheless, it is of course obvious to use such an effective combination of medications also in high-risk smoldering myeloma. And then to carefully examine in this ASCENT study whether this therapeutic approach can actually lead to complete tumor elimination and result in long-term remissions. Here as well, a time-limited therapy for a maximum of 24 cycles. So we are basically talking about 2 years of therapy, so shorter than the approved therapy with daratumumab alone. And they looked at the overall depth of response, at measurable residual disease response, but of course also at various side effects. The primary endpoint was stringent complete remission, that is CR, the disappearance of the paraprotein, and the disappearance of the clonal plasma cells in the staining of the bone marrow. And in total, 87 patients were treated here. And we see, also not unexpectedly, an effective combination of medications naturally leads to a high response rate. Almost half of the patients achieved stringent CR. Also, a very good response in 93%, MRD negative response in 85%. So these are all, of course, very, very good, but also expected response parameters. Here we have at least 5-year data, and it's worth noting that that is, of course, a significantly much more mature outcome than what we just showed with 9-month PFS rates. Here we have 82% progression-free survival. We have 44% who remained persistently MRD negative, and at least 80% of all patients were able to complete all 24 cycles. We see on the right side, there were indeed some discontinuations due to side effects, due to early progressions, and also due to deaths. So this therapy is not that easy to implement, especially when you consider side effects and also progressions despite therapy. And I think this curve here demonstrates this point very well. I find it exceptionally fascinating to consider the question of whether in high-risk smoldering myeloma that perhaps very different diseases are hidden within it. Because we see here that the progressions occurred almost exclusively during the therapy phase. That's 24 months. As if we have patients here who are carrying a resistant disease which does not respond even to an effective quadruple therapy and is primarily progressive, while after the end of therapy, starting from year 2, hardly any progressions are seen anymore. These are patients who have either benefited maximally from the therapy, or to put it critically, perhaps they don't even need the therapy because their disease wouldn't have progressed anyway. A biphasic pattern, which I find very interesting to consider when thinking about smoldering myeloma, and which I believe still deserves much discussion, and where hopefully we will have a lot more data on the molecular biology of the disease from the study. Few deaths, as I already mentioned. These were deaths due to these progression events, so very aggressive diseases that led to death. Few cases, but of course noteworthy. And of course also deaths that may have been partially caused by side effects. This is also a point that one would not want to see in a disease that, as a smoldering myeloma, would not be treated at all under standard care. I need to correct myself. This is the PFS rate for the MRD negative patients. These are the patients who probably benefited the most from the therapy and became MRD negative. This is the survival rate I just referred to, where you can see there are few events, but still there are events occurring during ongoing therapy, which we actually want to avoid. We don't want to see any deaths when we are doing a preventive therapy, which is actually intended to prevent deaths. There are definitely side effects. It is a quadruple therapy. We do have significant hematological side effects, meaning side effect rates related to blood counts, but for the most part, we see other side effects. Here too, there are indeed severe side effects. Fortunately, there are few therapy discontinuations, but as already mentioned, we also have deaths. Cardiac arrest, where it must be discussed whether carfilzomib could have played a role. We have a fatal case of the COVID-19 virus, and we also have a plasma cell leukemia, so a highly aggressive myeloma disease which could not be effectively overcome by this medical therapy. Here, once again, broken down further. So a broad spectrum of sometimes severe side effects. So this is not a therapy that just runs smoothly, that you can simply administer without considering the side effects. If we summarize here now, I think there is no doubt about its efficacy. It is very good and also very stable, looking at up to 5 years of progression-free survival, with the caveat that, caution, there were a number of relapses or progressions that occurred during ongoing therapy. When the therapy worked, it often worked very well, with a high rate of MRD negativity. And we see that 44% of patients remain permanently MRD negative, and that these are patients who, for a very significant number of years, will no longer see any activity of the disease. That would, of course, be a truly remarkable and positive outcome. The side effect profile is generally considered to be quite manageable, certainly if one accepts undergoing the therapy. Still, I think for a therapy that is started very early, especially the deaths, are already quite relevant. In the risk-benefit assessment, daratumumab, carfilzomib, and dexamethasone are highly suitable and effective candidates for a very robust and favorable clinical profile, effective therapeutic strategy outside of immunotherapies. But the authors themselves say one should examine new approaches and also consider immunotherapy. So from the options we have, we really need to choose wisely and consider whether a quadruple therapy might be the best candidate, because God knows it certainly wasn't without side effects here either. Again, the question about the consequences for everyday clinical practice. Clearly, this is not approved and would have to go through a long process if approval were to be sought. As mentioned, carfilzomib is not even approved for first-line therapy of active myeloma. Approved? Of course, we see the very good efficacy of CAD when combined with CD38 antibodies. But as I said, I see relevant toxicity and believe that for the treatment of smoldering myeloma, we need therapeutic concepts that bring significantly fewer side effects. Yes, that was the summary of 2 research studies that I found exciting and really thought-provoking, but certainly do not offer any ready-made solutions.
Yes, thank you again, Mr. Scheid. The problem, as you have already mentioned, with patients with smoldering myeloma is that they actually do not have any symptoms yet. On the other hand, however, they can suddenly develop symptoms due to the therapies, which is completely clear. These are all side effects that can occur And it is also said that these treatment methods are intended for patients with high-risk myeloma. However, we have quite a few patients in our community who have smoldering myeloma and who constantly ask, why am I not being treated here? Or they simply want the myeloma to be removed so that they can have peace of mind forever. Based on exactly which specific set of criteria is it being thoroughly and actually checked or evaluated, decided whether a patient with smoldering myeloma actually falls into the high-risk classification? And it is said, yes, in this case, it makes sense to use one of those well-known therapies such as daratumumab and Revlimid, and now possibly the recently published studies as an alternative option for therapy.
Or would you do it? Now, for the time being, we have the situation that something is approved. So we could simply do it if we wanted to. And of course, the patients wanted it too. But now we have to think about it. That's difficult, partly because of the assessment of the myeloma. We have many patients whom we have followed for years who show no progression at all. I myself have several patients in my clinic whom I have been advising for many years with smoldering myeloma, and there is absolutely zero tendency toward progression, where you can really say the patient agrees and the patients, we do nothing further and just observe because life is completely normal. I find it difficult to use daratumumab in such cases because even the depth of response is not comparable to what we have just seen. This is a monotherapy with an antibody where we can slow down the disease a little, achieve a partial response, but of course we cannot eradicate the disease. That's what many patients want. They don't want to see their myeloma just slowed down a bit, but they want the disease to be reduced to zero. For that, we would need concepts like the ones we just discussed. So very effective, but also more side effect prone approaches rather than working with dara-mono. That is why the therapeutic goal is often to achieve a much more intensive effect than we have with the approved approach. At the same time, however, we also want to avoid inducing severe side effects that wouldn't even exist without therapy. I think we are still at a crossroads here. The few patients we treat are often patients who do have symptoms, who have been dealing with neuropathy complaints for a long time, with bone pain, with fatigue, with a tendency to infections. So you could say this myeloma isn't entirely asymptomatic. We call it asymptomatic basically because of lab values. But clinically, the term doesn't really fit. And then you have the opportunity to say, let's see if we can offer a therapy here that will hopefully reduce the disease burden to such an extent that the symptom burden decreases. But you also see, both in clinical practice and in some studies, that when you look closely, especially if you critically assess the MRD, we actually find criteria for symptomatic myeloma there as well. Especially the focal lesions in the MRI are often a signal where we say we need to reassess the disease. It's actually no longer a smoldering myeloma. We now already have criteria for a myeloma that requires treatment. Yes, especially in patients where we take a closer look, where there are symptoms, my experience is that we then end up changing our assessment and say, now it is a myeloma that requires treatment because we now suddenly see more than one focal lesion in the bone marrow, in the MRI signal. And then, of course, we can immediately use one of the approved quadruple therapies and then actually treat the disease intensively and not just a little bit.
Yes, thank you very much, Mr. Scheid. That's important information. Since you say that when it's already extremely borderline, the smoldering myeloma, and one could almost already speak of symptomatic myeloma, which according to the criteria might not be perfect yet, but where you would say, yes, these patients would now be eligible for such early therapy. Thank you. And I think we can move on to the next topic, medical therapy, which has seen recent developments.
Exactly. Quite a lot is happening there. As mentioned, with the quadruplet therapies, we now have very effective options for patients both with and without a high-dose therapy option within the approved standard of care. Progress can't be stopped. We've seen that bispecific antibodies are very, very effective as induction therapy prior to high-dose therapy. In Germany, both research groups are now starting a large study where different concepts are carefully compared with one another again in connection with high-dose therapy. We are waiting for the data on CAR T cells in first-line therapy. Those studies have long been completed. We hope to see the very first initial data soon. However, while we are waiting, there is another concept here. namely to use teclistamab after high-dose therapy as consolidation therapy or maintenance therapy, whichever you prefer to call it, with and without the standard lenalidomide, which we have here as an approved maintenance therapy. This was the EMAN30, the Majestic 4 study, which was presented. It is not finished yet, it is just getting started. But here, data were shown from a safety run-in, that is a clinical research study where they aimed to evaluate the tolerability and feasibility if such a concept would be. These were adult patients who, after induction treatment, a high-dose therapy, had achieved at least a partial remission, so they had basically responded. And then they were divided into 3 cohorts with different concepts, which then tested teclistamab accordingly. And these 3 cohorts were ultimately structured and organized in such a way that the researchers decided to say, well, let's see if we can combine teclistamab with lenalidomide. And either teclistamab, as we are used to from relapse cases, is dosed closely monitored, so weekly, every 2 weeks, and then only later every 4 weeks, or whether we give it every 4 weeks right from the start. And then there was a third arm with teclistamab alone. We are certainly familiar with the side effects of lenalidomide, so I found it very interesting and appealing to test that as well. What if you only give the antibody and thus effectively spare the patient from lenalidomide, which is also a therapy with significant and burdensome side effects? The main question, of course, was whether I can significantly improve the depth of remission after high-dose therapy. Then, of course, the safety and tolerability in such a safety cohort, and of course also the other response parameters, especially MRD response, which is becoming increasingly important. So what kind of data have we seen so far? Regarding complete remissions, here you can see that approximately 50% of the patients had already achieved a CR after receiving high-dose therapy. As expected, this could not be increased to 100%. Also, many MRD negative rates. After 18 months, the patients were largely progression-free. Of course, these are much too short timeframes for such assessments. You often need 5 to 10 years to fully assess progression-free survival with such highly effective therapies. Grade 3 and 4 side effects, an important issue with a high percentage rate here. CRS is less of a therapy factor here. That has usually been mild. But of course, it is to be expected with these antibodies during the dose escalation phase. It's important to really get a clear sense of how these arms work. What is there to gain if I now combine lenalidomide with such an antibody or give the antibody alone? And you can already see in all cohorts, I have this massive improvement in deep responses. You can see these brown bars for the stringent CR. The patients already show some response from the high-dose therapy, but this deepens dramatically when I add such an effective immunotherapy afterwards. And we see that this more dose-dense teclistamab already produces more responses, at least in the short term, compared to the administration every 4 weeks, where only 3/4 of the patients achieved this stringent CR. But whether this is really clinically relevant in the end remains to be seen. In any case, we have, with all 3 cohorts here, in any case, a very, very good improvement in response, and the MRD negative CR is achieved in 100% of cases here. Teclistamab alone only reaches 90%. As I said, maybe it just takes a bit more patience than just looking after 1 year to assess, also small case numbers, but overall one has to say everything worked well. Progression-free survival at 18 months is, of course, much too short to be able to see anything, and especially to be able to detect any differences. There was nothing yet in this cohort study. We'll only see that in the large phase 3 study, where these concepts can actually be compared in a large number of patients. But of course, it's extremely important now to look at the side effects. Here we already see 3 or 4 side effects in particular. Almost 100% in the combination cohorts, 2/3 in the monotherapy group. So these initial signals suggest that monotherapy might potentially be the more attractive choice in terms of side effects. Significantly less neutropenia, bone marrow toxicity is clearly better. Infections are a major issue. 1/3 to 1/4 of patients were in need of regular immunoglobulin substitution, although ultimately every single one of the individuals in the study went on to develop an immunoglobulin deficiency. In my opinion, there was not enough counteraction taken. That could be an explanation for the infection rates. that not enough was done to prevent infections, but 9 patients had to discontinue therapy. So the feasibility seems to be relatively good, but it is not quite excellent either. A closer look at the side effects. It's a very full table. But if you look across, you can already see that respiratory tract infections, abbreviated as WRTI, right at the top here, are somewhat lower in these less frequently administered teclistamab dosages. Every 4 weeks seems to be very favorable here to reduce infections somewhat. Otherwise, many side effects are ultimately known from LEN, like diarrhea, for example, which was significantly less common in the teclistamab monotherapy. One can definitely say that the side effect profile is somewhat better presented when I administer teclistamab as a monotherapy and not together with LEN, because the two side effect profiles do indeed complement each other, so to speak. And things like fatigue and diarrhea are significantly more pronounced compared to monotherapy. Let's take a closer look at the infections again. We see the respiratory tract infections, COVID cases, which were distributed fairly evenly. We also see things like influenza, and the occurrences of pneumonia were being somewhat significantly less frequently observed in the treatment arms that received teclistamab only every 4 weeks. So I think this clearly demonstrates to us that these exceptionally potent and effective antibody therapies need to be adjusted for situations where the tumor burden is low and the therapeutic pressure is lower, and you can take more time to achieve the maximum effect so that you don't want to have too many infections in the early phase. And this trend becomes even more apparent when looking at the timing distribution. In this graph, you can observe how the rate of infections is plotted out over time. We see this clear and significant surge of infections in the first 6 months. This is the phase of intensive therapy and dose escalation when you really have to keep a close eye on the patients. And then starting around month 6, you can see that this monotherapy arm performs significantly better than the 2 combination arms. I think more is better is not always true. I believe this idea of preferring to use teclistamab as a single therapy and to extend the intervals, and I dare to say perhaps it would have been wise to give the injection only every 8 weeks and thereby avoid even more infections, could be another good approach. I think this therapy is very exciting, very stimulating to discuss, but it does not yet represent a form that is already optimized for this specific setting of maintenance consolidation therapy. So of course it is entirely feasible and manageable to handle. The side effects were now appearing, not exorbitant, but still significant. Infections were manageable. The authors concluded here. I would put a certain small question mark on that. I think maybe one could carefully take a closer look at whether all patients truly received enough immunoglobulins, whether everything was really done sufficiently to prevent these grade 3 to 4 infections, which are highly significant and serious infections that occurred in a quarter to a third of the patients, from happening. We see excellent responses, absolutely no problem. That's perhaps also why there is room for further de-escalation strategies. Progression-free survival rates, of course, are not very meaningful in the short term. Naturally, we will now have to wait for the large randomized part, where teclistamab with or without lenalidomide will be tested against lenalidomide maintenance in a large patient population and then followed up consistently over several years. To summarize this again for everyday practical clinical application, we have something that is obviously very effective, where we is capable of achieving high remission rates. But I still want to strongly emphasize the critical point regarding potentially serious infections and the need for immunoglobulin administration. And of course, we discussed this. Now that we have this knowledge that these antibodies are very effective as induction therapy and, as shown here, are very effective after high-dose therapy, even the presenter discussed, well, shouldn't we use this instead of high-dose therapy? And not as an addition, do we even still need high-dose therapy? If we can already achieve therapeutic success before high-dose therapy with MRD negative remissions in 100% of cases, and then even provide maintenance therapy afterwards. So I really want to emphasize this point again here. I believe we are now seeing the emergence of concepts that will make things even easier for us in the future. Mind you, the future, not everyday clinical practice at the moment. To imagine treatment without high-dose therapy. What else is there? We have the CELMoDs as cereblon inhibitors. So in a sense, a further development of the IMIDs, that's also something that I think for a long time has not really been utilized in therapeutic concepts. That's why I was pleased that we observed a specific treatment regimen here for patients who receive a quadruple therapy completely independent of their eligibility for high-dose therapy. And here they tried to replace lenalidomide, which we have already discussed earlier, as it is not entirely free of side effects, with a CELMoD, in this case, iberdomide, which in terms of side effect profile and efficacy profile is certainly much more promising than lenalidomide. And this was combined with DARA-VD. So essentially, they modified the DARA-VRD regimen to create an IBER-DVD regimen. And the whole thing was tested in a phase 1/2 study called IDEAL, a small cohort, 44 patients, initially to assess safety and efficacy. There was a high proportion of high-risk myeloma included, and the question was whether this improvement in efficacy of a CELMoD, in this case iberdomide, could actually be translated into a more effective 4-drug regimen. What I also found interesting was that the entire treatment was limited in duration, meaning that this 4-drug therapy was administered for 15 cycles. And then a year of maintenance therapy was added afterwards. So a very time-limited therapy for patients who were not supposed to receive high-dose therapy as a primary treatment. The primary endpoint was the remission rate, specifically complete remission. But of course, MRD negative remission is now indispensable for being able to assess a therapy and also to estimate the long-term success of the treatment. All patients responded, which is good news, but also not entirely unexpected with such a 4-drug combination. About 1/3 achieved a complete remission. Over the course of the therapy, half of the patients ultimately achieved this complete remission as well. You can see that the duration of therapy is important. Here, MRD negative remission in the bone marrow was examined, which was achieved by just under 30% of the patients. And over the longer course of therapy, almost half achieved it as well. And we are seeing very promising 12 and 18-month. These are the progression-free survival rates, which are illustrated here in this graphical format. So at a first glance of these results, it looks quite good. Of course, one must now critically note and consider that with the available immunotherapeutic concepts, we are seeing significantly flatter curves for progression-free survival. And one really has to ask the question, does it make sense to further develop a therapy when after 18 months already over 10% of patients have developed a progression? Is that still up to date compared to the aforementioned immunotherapy concepts, as well as CAR T cells, for example? I would want to put a question mark after that. It's also important to ask, how is the tolerability? Today, we need therapies that are very well tolerated. Infections here, grade 3 and 4, that adds up to about 15%. So significantly fewer severe infections than what we just saw. Here we see a clearly safer therapeutic concept than perhaps compared with the antibodies that were just demonstrated. Otherwise, also very little severe fatigue, for example, little severe diarrhea. So perhaps here is an indication that you would always have a regimen which basically does not have certain typical side effects of lenalidomide as strongly pronounced. However, you do see high rates with the milder side effects as well. 50% diarrhea and almost 70% rash. So it's not entirely without issues either. This is not the solution to all problems, but it might indeed be a concept that seems worth considering further. So further optimizing a quadruple therapy regimen here. As I said, the data are still far too immature to look at long-term survival. But even now, there is a certain signal that such a therapy might not quite be able to keep up. Otherwise, the side effects are generally manageable, especially the low rate of severe infections. I find it very interesting to look at this fixed therapy period, that patients are not treated for many years, but rather that treatment is limited. And that's also my conclusion. I find using CELMoDs as combination partners in quadruplets to be very interesting. I also find it appealing to use limited duration therapy, even in active myeloma, not just smoldering myeloma, as we saw earlier. I also consider the side effect profile to be rather favorable. In terms of efficacy, I would rate it as promising for now, but I have pointed out that we have a very competitive environment. And the question is whether these data are still sufficient to really keep up in the context of modern, highly effective and sophisticated immunotherapeutic treatment concepts in first-line therapy. Another incredibly exciting prospect is the concept we are discussing of considering BCMA-targeted therapies not only in CAR T cells or in antibodies, but also not to forget the third option, namely the very recently reauthorized and approved antibody, which as a conjugate, as a specialized molecule that is coupled with a potent toxin, is now newly available on the market as belantamab mafodotin. And this is a substance we have known for a long time from its previous approval in the relapse setting, and which is now attracting a lot of interest again, specifically as a combination partner in a wide range of regimens. In order to achieve, even here in first-line therapy, perhaps a more favorable and sustainable balance between risks and associated side effects. Here is a comprehensive update on these specific patients who were not eligible for high-dose therapy and who received BELA-DRd here. So an immune conjugate against BCMA, a CD38 antibody, and then lenalidomide and dexamethasone. So the DRD is not supplemented with a proteasome inhibitor, as we know it from the other quadruple therapy, but here the proteasome inhibitor was omitted, and a BCMA-targeted immune conjugate was administered. That was the specific study design. The patients had a median age of 73 or 74 years old, and as previously mentioned, the BCMA-targeting antibody drug conjugate belantamab mafodotin was here combined with DARA-RD as the standard therapy. Initially, it's about dose finding. You have to carefully consider and approach what works together with the medication triplet combination. Especially the associated ocular side effects are very well known and thoroughly documented. Photosensitivity, corneal irritation. These are things you don't want to have in this first-line therapy. They looked at how the dose could be adjusted, lowered, could be adjusted. In particular, the interval was significantly extended here. We usually administer it in the approved form every 3 or every 4 weeks. Here, from the start, it was only given every 8 weeks. And at some point, the interval was further extended to 12 weeks. So a low dose plus a long dosing interval is certainly an important point here. And it was examined whether patients need to be seen by an ophthalmologist or whether a hematologist could also examine the patient with basic medical instruments and advise whether they observe any ocular side effects or can continue the therapy, which also significantly simplifies the feasibility of such therapies. The primary endpoint was first the safety and side effects, especially the ocular side effects, and the management of these ocular effects either by an ophthalmologist or a hematologist. And only as secondary endpoints were response and deep remissions evaluated. What were the results? We achieved a very good overall response rate of over 90%. We have 70% complete remissions. The efficacy is very clearly demonstrated here in such a 4-drug combination. High MRD negative remission rate of over 80%. And again here, with all the limitations of the relatively brief observation period, 18 months of progression-free survival is exceeding the 90% mark. So these are highly encouraging and promising clinical data regarding short-term therapy outcomes. But of course, we need longer follow-up and larger patient numbers to better assess this. Graphically, this looks like we have hardly any events here in the early follow-up period. So these are definitely effective combinations. But as we can see, as we just said, 80% 18-month PFS may no longer be competitive. Over 90%, I would say, puts us more in the range where you would expect that you can really say, okay, in the first 1.5 years, progression events should truly be rare with effective therapies. We aim for the majority of patients here to remain in remission and maintain a stable response. When we examine the specific side effects observed in these 2 cohorts, we see that fatigue was certainly a significant issue, which is most likely attributed to lenalidomide as a substance that also brings other adverse side effects into play. When it comes to eye-related side effects, belantamab mafodotin is clearly the primary agent to blame. This is also well known from monotherapy. However, we see that the severe eye-related side effects, such as reduced visual acuity, keratopathy, meaning corneal damage, which, as we know, regresses well with waiting, but of course still represents a burden, are significantly less frequent here than we would expect. So here it has apparently already had a very positive effect that the dose was adjusted, and above all, that the dosing interval of 8 weeks is much longer. Nevertheless, of course, some of the doses were inevitably skipped in about a total of 27% of the time, or 11% of cases. What is important here is that these eye-related side effects resolve quickly. You have to wait about a month here. And in the meantime, you can also stick to the break, since we only administer it every 8 weeks anyway. And in that case, you might even postpone it again, saying, okay, if I wanted to resume therapy after 8 weeks, but the patient is still experiencing symptoms, then you postpone it by another 4 weeks. And then you're at a 12-week interval. So this approach has proven to be very effective. And we see that the effects on the eyes could really be limited to a subset of patients and no longer affected the majority of patients. There were also fatalities to mourn here, and these were mainly due to infections. So once again, infection remains a critical issue that we definitely need to always keep in mind. But to provide a brief summary, once again, we have a highly impressive level of efficacy. And with all due caution, we also have very encouraging preliminary interim results at 18 months. The ocular side effects here are significantly milder compared to the data we were familiar with from earlier. And we see that for many patients, serious side effects only occurred in 10 to 20% of cases. You can see that the hematologists are very good at assessing this. And both management strategies, whether equipping the hematologist with a few vision tests or involving the ophthalmologist, both worked equally well. And that's why you can summarize it like this for everyday clinical practice. Here we have a look into the future with very good data on efficacy and tolerability. We have learned, and it has also been confirmed here, that we should use low doses and plan for a long interval from the outset for the therapy. We should get used to the fact that as hematologists, we are indeed capable of accurately assessing ocular side effects. And I would like to point out on my own behalf that we are planning a study with belantamab mafodotin and VRD in combination. Compared to DARA VRD, which is scheduled to start around the turn of the year, with many centers in Germany and both study groups conducting the study in parallel with colleagues in the USA. And this is intended to once again fully harness the potential of such a combination therapy to help patients who are not eligible for high-dose therapy. Yes, with that, we have discussed a few highlights from first-line therapy. And Mr. Eisenbeisz, I look forward to your questions.
Yes, with the current standard quadruple therapies, we have already achieved very good results. There is talk in some cases that patients who, after 4, 5, or 6 cycles, can already achieve MRD negativity, so that some scientists are already saying that with these therapies, progression-free survival of well over 10 years can be achieved. And if you now look at what else is in the study pipeline, the whole story goes much further. And that is truly and incredibly fascinating, hopeful for patients. However, the question that keeps coming up, especially now for patients due to the good results of the quadruplet inhibition therapy, is what sense and what necessity there actually still is for high-dose therapy. You briefly mentioned that people are now also starting to reconsider this, but what is the current status at the moment? What should be considered for a patient deciding whether or not to do high-dose therapy?
Yes, that is certainly a tricky question. I always try to discuss in detail with the patient what data we have, which serve as the basis for our decision. And the data we have on high-dose therapy all come from a time before CD38 antibodies were introduced. So that's the first major limitation, that we actually don't have any reliable data to be able to quantify the benefit in the context of quadruplet therapy. So that's the first significant gap in the data we already have, as it is. And then, in addition, we generally have this data only until they reach the age of 65. So for patients up to 65, I would always argue that we can infer that high-dose therapy offers a distinct clinical advantage based on data from the time before antibody-containing induction therapy, and we can postulate that this advantage might also carry over into the era of more effective induction therapies. But that's already a kind of extrapolation. That's why I always talk about maximum therapy and say, if you want maximum therapy, if you feel fit enough for it, and also have the desire to make use of everything we have available, then high-dose therapy is certainly an important component of treatment. And in such a modular overall concept, High-dose therapy is then one building block among the induction therapy, a possible consolidation therapy, and 1 or 2 rounds of maintenance therapy. But if there is a lingering sense of skepticism, am I physically fit enough for this? Am I perhaps too old, or am I truly willing to accept these side effects, such as hair loss, hospital stays, inflammation of the mucous membranes? Then I now have many patients who say, I will forgo this high-dose therapy. Maybe I'll do a stem cell collection so as not to completely give up this option, or to be able to fall back on stem cells later on. But for now, I'll wait and see how the quadruple therapy, which is effective, works. If I have an optimal response after 3 or 4 cycles, then I might continue on this path without high-dose therapy. I think we should be very open about this and strive for good shared decision-making with the patients. And as hematologists, we should also be very transparent about which decisions we actually have data for, and where, in the end, we are making projections, making an assessment. When we look at the final results, we have the data from the high-dose studies, which may potentially extend well past the 10-year mark. But even the data with quadruplet therapies are not bad either. There too, we have projections of achieving progression-free survival times of perhaps 9 years. And of course, we have some very interesting relapse therapy concepts. So I think we need to discuss this openly and really make it clear to ourselves that for real decision-making, we don't have hard evidence because the studies are missing. We are seeing concepts like the MIDAS study, which is investigating whether high-dose therapy can be omitted based on MRD guidance. There too, we will have to wait many years until we really have reliable clinical results. In the meantime, we have to go over the data with each individual patient. We will thoroughly explain the situation to you and then help you make a well-informed final decision. And we are also providing comprehensive digital tools such as decision aids and shared decision-making processes to support your journey, so that even before a doctor's appointment, patients can orient themselves, get an idea of what it's actually about, which data are available, what assessments exist, and which side effects they might have to expect. I believe we also need to support patients from our side to assist them in approaching this in a step-by-step manner, because it's not a black and white decision.
Thank you for this assessment. It's very good, especially to discuss everything with the patient individually and make decisions accordingly, and especially for the note that even if you don't necessarily want to do it, high-dose therapy, you should still collect stem cells in time. Because what you have. The longer a therapy lasts, the more difficult it becomes, as far as I know, to collect stem cells as well. This also means that patients should think early on about keeping this option open for a possible later high-dose therapy, just to be safe. Yes, thank you very much. And what comes next after an initial therapy? As you mentioned, a relapse cannot be ruled out. We'll discuss the options available for that in the second part of our coverage